right, we've reached the half-hour mark, so let's get started. Welcome everyone to this week's installment of AMSSM's National Fellow Online Lecture Series. My name is Matt Wise. I'm an assistant professor in family medicine and orthopedics at UT Southwestern. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on physeal injuries, which will be given by Dr. Shane Miller, actually 2 weeks from today at the same time. For tonight, I'm very excited to welcome Dr. Lyndsey Booker to speak to us on transient neuropraxias in athletes. Dr. Booker graduated from medical school from Indiana University and completed her P1R residency at the University of Washington. She then went on to complete sports medicine fellowship at the University of Utah. She's currently an assistant professor at the University of Washington and serves as head team physician for UW Rugby. Before we get started, we also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, to provide fellows with direct access to educational experiences with AMSSM members and at times invited guests, and most importantly, to assist in CAQ exam preparation. Some reminders to please mute your device's microphone and turn off your video. Please submit questions through the chat function, which I'll monitor over the course of the lecture. I, as the moderator, will ask the questions during the Q&A at the end, and then please remember to complete the evaluation at the end of this lecture. Lastly, one of our new efforts is to facilitate more input from our audience, and there are a couple of ways to do this. First is a web link that can be found by going to amssm.org. Click the Education tab and then select Fellow Online Lecture Series. The link is near the top of the page as seen in this screenshot. Second is by scanning this QR code. So it should take you directly to the form to fill out. And when filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. Now, without further ado, please welcome Dr. Booker.
As Matt mentioned, I'll be chatting about transient neuropraxia in athletes. And this is a great time, I feel like, to have this discussion, just given the high school, collegiate, and professional football seasons being underway. And then from my perspective, working with rugby, we also have our fall season upcoming as well. And then amongst all the other sports that are occurring throughout the year as well. Don't have any disclosures. And I just wanted to give a brief shout out to a couple of different people, some mentors here at the University of Washington with Dr. Stan Herring and Dr. Omar Bhatti. They've been a great resource in particular with this topic and their work with the Seattle Seahawks. So I appreciate all of their wisdom. And then I want to give a shout out to my residency program, University of Washington here, where I'm now back on as faculty. And so it's great to work alongside some of the mentors that really got me interested in the field and prepared for this stage in my career. And then lastly, I wanted to shout out the University of Utah non-operative sports medicine fellowship, as well as the operative fellowship, where we got to work with them closely as well. Learned a lot during that fellowship year, had a great time, and really prepared me in particular with this topic, amongst other things, throughout the year for sports medicine. So thank you all. Also, there's a bunch of different talks already out there for over the last couple of years related to cervical spinal cord injury or cervical spine injuries in general. So this can be helpful to go back and review, as it may not be exhaustive with the more niche topic of the transient neuropraxias today, but helpful to review those other talks in preparation for CAQ as well. In terms of the objectives, we'll be talking about the stingers and transient quadriparesis, in particular, the anatomy, the epidemiology, the mechanisms of injury for those conditions, and then how to assess and manage them. And then lastly, we'll review the evidence of return to play and then the controversies surrounding those injuries. So we'll start with the initial case. So we've got a 20-year-old collegiate football player who comes to the sideline reporting difficulty with lifting the left shoulder. He also reports having numbness throughout the arm. We review the video of the last play of them carrying the ball down the field and see that they're hit on their right side, landing on the left shoulder, and the neck is extended and then flexed laterally toward the ground. So with that type of mechanism, there's a couple of different things that we would be thinking about, whether it be stinger, a cord injury, as a cervical spine fracture, or an injury to the shoulder itself, where sometimes with dislocations, you may expect to have some of those sensory changes. With a little bit more information, on the sideline, you note that they don't have any tenderness of the cervical spinous processes, normal range of motion, negative Sperlings, but they do have diminished sensation diffusely in the arm, and they have some weakness with shoulder abduction, elevation, and then elbow flexion. And then the reflexes are normal in both upper and lower extremities. 5 minutes later, you do another reassessment, and the athlete reports their symptoms are now resolved, and they're eager to play, get back on the field. Normal, pain-free shoulder range of motion. Cervical spine is benign, and then the neurologic exam is otherwise unremarkable. So that narrows our differential down a little bit and has us thinking that this may be a stinger or a burner injury. So we hear these about these types of injuries, but it's a little bit more complicated in terms of what actually is going on. So a stinger is a nerve injury occurring at some point along the either from the nerve roots to the plexus region. And it's been described as a bunch of different types of with a bunch of different names, burners being one, transient brachial plexopathy may be described, and then cervical nerve pinch syndrome was also a description earlier on with this type of injury. In general, we expect people to have that unilateral pain, and it comes after there's a blow to the head, neck, or shoulders. So when we're trying to frame our heads around the stinger injury, we want to think about the anatomy involved there. So up in the upper right-hand corner, we've got a cross-sectional view of the spinal cord with the dorsal root and the ventral root making that spinal nerve, and then the dorsal and ventral ramus. And then these ventral rami go on to form the roots. So we've got the roots from C6, C5 all the way down to T1. And then those then divide further and form the brachial plexus from the trunks, divisions, and cords. And so that's situated in the supraclavicular region. So if you can imagine a stretch injury or a compression injury to this area, we may expect some type of nerve involvement. In terms of stingers themselves, it's a pretty common injury in contact sports, the most being football and rugby. But as I mentioned, it can occur in other types of sports such as wrestling, gymnastics, hockey, basketball, boxing, weightlifting, etc. In a study that was done on NCAA Division III football players, 65% of them reported that they had at least one stinger in their collegiate career, but 70% of them reported that they did not report this to medical staff. So it can be a little bit tricky looking at the statistics regarding this injury to have a full understanding because it's often underreported. Stingers are included in the NCAA statistics for cervical spine injuries. And so in a study that was done, they found that looking at injuries across different sports and body regions, cervical spine injuries were 4 times more common to occur in games than in practice. So something to think about as seasons coming underway and preparation for the games ahead. So like we said, unilateral symptoms are the hallmark for the stingers. If there's any concern about bilateral symptoms, we need to be thinking about something else. So the main features would be stinging or burning pain in the supraclavicular area, or it may involve radiation down the arm. Sometimes athletes may have decreased range of motion in the neck, but not always. And it's typically a circumferential pattern for the pain. Numbness and tingling can be involved with this, and it can vary to different degrees. And similarly with the weakness in the arm, it can either be mild weakness with that 4 out of 5 strength, similar to the case we presented, or paralysis, meaning they're not able to move the arm at all. Oftentimes, though, we expect for this injury to resolve. And so it usually only lasts for a few minutes, but it can last up to 24 hours and sometimes longer. But that is not typical. There are a couple of different types of mechanisms that have been described in regard to a stinger. One being a traction injury. So thinking about the neck, where there's shoulder depression and the neck is flexed to the contralateral side with more of a stretch on the brachial plexus. Another type of mechanism may be from a direct blow, something landing directly on that region or being hit in that area. And that would also affect the brachial plexus. And then one of the other common mechanisms of injury for stinger would be from extension of the neck and then ipsilateral flexion. So more of a compression type injury affecting those cervical nerve roots. So is there a most common type of mechanism of injury? That's a tricky question. So Clancy in 1977 had a report early on about 13 cases of brachial plexus injuries in football and wrestlers. There were multiple mechanisms described, even more than what I just proposed on that last slide, including having lateral rotation involved as well, and also landing directly onto the shoulder. They did EMG studies on all of the athletes that were involved, and it did show that there was more of an upper trunk involvement. So that gives us a little bit of an idea of where this may be occurring along the spectrum from the roots all the way through to the brachial plexus. Meyer also did a study in 1994 looking at 40 collegiate and pro athletes with stingers, and a grand majority of the athletes had that extension and ipsilateral compression mechanism. None of them had any direct trauma to the suprafollicular region. And then Levitz in 1997 studied about 55 athletes with recurrent stingers. So this is more than one occurrence. And they also had a large majority of the athletes with the compression mechanism. So they proposed that the lesion or the injury is actually occurring at the nerve root level due to the compression in that neural foramen, as opposed to more distally in the plexus. So there can be a little bit of variability in where the injury occurs. Thinking about nerve injury and how this may come about, we want to go back to the basis. So thinking about axons, those nerve fibers, they're surrounded by the myelin sheath, and then they have casings that bring these different axons together, and then multiple fascicles of nerves are then surrounded to create the spinal nerve. And so when there is a stretch or a neuropraxia, as we're discussing, that's typically an injury to that casing or that myelin sheath, and the axon is intact. And so it's that type of injury we expect to be temporary, but it can involve motor and sensory deficits. A higher grade injury would be axontomesis, and so that may involve some axonal damage where Wallerian degeneration can occur, but there is still an intact axon. There hasn't been a complete transection as we would see in a type 3 injury, which is neurontomesis. So with the stinger, in general, we expect it to be that type 1, but if there is a recurrence or other persistent symptoms, then we might think it is a axontomesis. So with that common mechanism that Meyer and Levitz had described being more prominent, there's a thought that athletes with foraminal stenosis, so narrowing of the space where the nerves exit, may be at more of a risk for having recurrent stingers. And so Meyer found that there was a 3-fold increase in sustaining stingers for those athletes with foraminal stenosis. And then Levitz also reported that 93% of the athletes, when they had MRIs done, had disc disease and narrowing to the foramen as well. And then there was a study out of Japan where they looked at 49 collegiate football players, and they found that there was a increased risk of having a stinger when you had cervical disc disease or decrease neck extension range of motion. So these are some things to think about. It can be a little bit controversial in terms of does it necessarily correlate versus not, but in general, we want to think about why somebody might be having a recurrence if they do present in this way. So on the field, we'll want to treat all these injuries like it's a cervical spine injury initially until we have more information. So you want to stabilize the spine, ensure there's a patent airway, that breathing appropriately, and normal circulation. You also want to do an inspection exam, looking for any signs of vascular injury, swelling, deformities, and discoloration can also be helpful to identify. And then we'll want to move on to the neurologic exam. So we'll look at testing the different myotomes and dermatomes. And this is typically done after we have ensured that the spine is stable. History is also important when we're evaluating for stinger, because it can help with the guidance that we give the athletes and the teams. And so if they have had a previous stinger, that can affect how we counsel them and the management. And then if they've had a prior neck injury, that also can be important for us. So in the midst of doing this evaluation on the field, if you can't rule out a cervical spine fracture, cord injury, vascular injury, we want to stop and not proceed with the rest of the exam, and they should be stabilized and transported to higher level of care. But let's say in the case of our athlete, they didn't have any tenderness, there was just unilateral symptoms. So we bring them to the sideline and conduct additional evaluation. So we can test that range of motion in the arm, with the shoulder, as well as the cervical spine. If there's any increased pain in that, then that will limit our exam and may consider further evaluation for a cervical spine injury. There may be some weakness, but again, we expect that to resolve during the course of time. Spurlings can be a helpful maneuver to utilize, as it allows us to see if there's any evidence of like a cervical nerve root compression. So as you can see in the diagram, the provider is extending and laterally rotating the neck and then applying an axial compression. If there is concern for a cervical nerve root injury or radiculopathy, sometimes you can just do the modified test where you don't necessarily press down on the head, but you allow that athlete or patient to do the maneuver without the compression. I usually start with this, and if they're having significant pain, then I won't move forward to try to make their symptoms worse with the axial compression. But in general, after we do our assessment, if the symptoms are still lingering, then we'll want to proceed with additional evaluation. So again, repeating that neurologic exam on a serial time frame. If they're having a lot of pain, we'll want to rest the limb, and we can do what's called like Bocodi sign, is basically taking some of that upper limb tension off, and then also help control the pain. We'll consider imaging when indicated, especially if there's ongoing or persistent symptoms. And then rehabilitation is also considered if there's persistent weakness or difficulty with range of motion in the neck or the shoulder. In general, this is more of a self-learning process, so history and physical exam can help us make that diagnosis. But if there are ongoing symptoms, then we'll want to at least start with some cervical spine x-rays. In the more acute setting, you want to start with an AP and a lateral. And then if there's not any significant tenderness or concern for fracture, and the range of motion is restored, then we can include a flexion and extension view as well. And that can allow us to assess for any sense of instability in the cervical spine. And then more advanced imaging beyond the cervical spine x-rays would be an MRI. And so that allows us a little bit more detailed look for disc herniations, any bone spurs, and then also to evaluate for the size of the central canal. Plexus MRI is not routinely considered, but if there is concerns for more peripheral injuries, then that can be ordered as well. And EMG can also be a helpful tool to use, particularly with persistent symptoms. Oftentimes, if there's not, if the symptoms are resolved, then EMG may likely be normal. But if they're persistent symptoms, then we may expect to see some changes starting around 3 to 4 weeks after, thinking about that time course with Wallerian degeneration. And so EMG can help us sort of differentiate between whether it might be a nerve root problem versus an injury throughout the brachial plexus. So when we have an athlete with this and taking in consideration all of the history and exam, then we want to think about what's the next step. So if the symptoms are resolved and they want to go back in the game, if this is a first-time stinger, then and they have rapid resolution, the general guidelines from various sources recommend that they can go back into the game. And if they have a second stinger in a separate season, then they can also return back if all of their neurologic exam is normal. But we want to take a step back and think about it a little bit more. If this is a second stinger in the same season or a third stinger, even if the symptoms have completely resolved, we want to look into it a little bit further to see why exactly that's occurring. And then in general, if they are having a third or fourth stinger with multiple persisting symptoms, then we may want to talk to them about limiting their involvement in contact sports. Prevention is something to think about as well with the stingers. And so emphasis with this would be on proper technique. So spear tackling, fortunately, is something that was banned from the National Football League and then subsequently NCAA and the High School Federation as well. And this particular type of tackle is having someone land directly onto their neck in a straight position. And so this ban significantly decreased the amount of severe spinal cord injuries. And so having that change is definitely helpful for prevention purposes. Sometimes people wonder whether a football collar may be helpful in the sport of football. In general, the goal behind using the cervical collar or the football collar is to decrease your neck extension, but in turn that may put your cervical spine in more of a flex position, especially with a high impact or a high load. And so that may be concerning for more of a flexion. It may be more concerning for something to discuss amongst the medical providers and the athlete themselves to decide whether this is something that is worth it. Some of the literature that has been done with regard to the use of different types of collars showed that the Kerr collar, on this one on the end here, provided protection amongst these three collars the most, with like acceleration of the head and then force transmission. And then the cowboy collar didn't provide as much of that same protections. And then another study was done that showed that the collars can help with limiting cervical hyperextension, but both of them are done in a situation with a controlled environment and not necessarily in live gameplay. So that evidence should be used in a limited fashion. All right, I know it's late on the East Coast for a lot of you all, so thanks for sticking with me, but we're on the home stretch. And we'll hit the second half of the talk here. So our next case is a 25-year-old professional football player. You see them laying on the field after they're tackled or after they tackled the team's opposing running back. So you assess them on the field. They tell you that their neck extended back during the tackle. And they're reporting weakness and sensory changes in the arms and the legs, and they don't feel like they can get up. So immediately our concern would be, is there a spinal cord injury here? Other differentials would be transient quadriparesis, thinking about a fracture or dislocation in the neck, a TBI, brachial plexus injury, or stinger. So with additional information, you note that the athlete is awake and alert, they have normal vitals, they have some tenderness along the cervical paraspinal muscles, but no tenderness on the spinous processes. And immediately they're not able to wiggle their fingers and toes. they've got diminished sensation throughout their arms and legs, and you decide to defer the rest of the exam to stabilize the spine. So in that process, the athlete is adequately placed on the spine board with cervical spine stabilization. They are transported via EMS. And during that time, the athlete says, hey, my legs are feeling better. I don't have any abnormal sensation. Everything feels normal again. But given the mechanism and the initial symptoms, there's still a concern there for something else going on. So we obtain additional x-rays and a CT scan, but both are negative for fracture or dislocation. And then neurologic exam at that point is repeated and it's normal completely. So now we're thinking this may likely be transient quadriparesis as the symptoms resolved in a fairly short time frame. So we want to think about the anatomy when we're talking about the cervical spine and the spinal cord itself. We've got the 7 vertebral bodies, and then we have the 8 cervical nerves that come out. So all of them, except for C8, exit above the level of the vertebra that they're located at. So C1 exits above that C1 vertebral body. And then when we look at a cross-sectional view, we can see that we've got the intervertebral disc that's anterior to the spinal canal, got the spinal cord, and then as we looked at previously with stingers, this forms that cervical nerve, and which exits on both sides through the foramen. And so this can be important to think about in terms of how this may affect, how this injury may come about and how it affects their future. So transient quadriparesis is a rare spine injury, first reported back in 1986, and the hallmark features were that it was transient motor and sensory symptoms, typically lasting for a few seconds, but could be a few days. And typically this occurred after some sort of axial compression with flexion or extension to the neck. It's also been described in the literature with different names. So cervical cord neuropraxia, cervical cord contusion or concussion, and then burning hand syndrome or commotio spinalis are also names that you may see. In general, injuries to the spinal cord in the United States are occur at a rate about 10% during sports. And transient quadriparesis in particular is most commonly occurring in football, oftentimes due to people leading with their head when they're tackling. Other sports that may have these injuries would be other collision sports, but thinking about boxing, hockey, rugby, wrestling. Torg's group in 1986 reported that 1.3 episodes were sensory motor, so involved sensory and motor for per 10,000 athletes. And then there was sensory only in 6 episodes per 10,000. And then Bowden had a study in 2006, a little bit later on, that showed a little bit lower of an incidence with 0.17 per 100,000 in high school and 2.05 per 100,000 in NCAA. So their combined rate was about 0.9. As mentioned, when we're thinking about the differential for this, if we note having any neurologic changes in 2 or more limbs, we'll really want to be on high alert for a spinal cord injury, including the transient quadriparesis. So it typically has sensory or motor changes, and it can involve all of the extremities. It could involve just the arms, it can involve just the legs, or just the right or left side of the body. So that can be important because we want to be able to recognize these different patterns because of the acuity of the situation. Typically, the symptoms are temporary and resolve in a few minutes to a couple of hours. And neck pain isn't a primary symptom, but it can occur. Torg also looked at 110 patients that had TQ And about 40% of them had plegias. They presented with paralysis, and 25% of them had paresis, meaning they had just weakness with some movement essentially. And then 35% had only sensory symptoms. The large majorities resolve within 15 minutes, and a grand majority of them were in all four limbs. But as we can see, it can occur in other fashions with just upper or lower extremities being affected or just on one side. And there was also a recurrence rate in these athletes of about 56%. The thought process behind the mechanism of injury for this is not completely understood, but one of the proposed mechanisms is what's called a pincer mechanism. And that can occur from both a hyperextension or a hyperflexion moment. And so when there is extension of the neck or hyperextension of the neck, we think about the core being sort of compressed between the superior vertebral body as well as the lamina of the inferior vertebral body. And then in the opposite way with flexion, we would expect that lamina of the superior vertebral body to narrow that space or pinch between the superior aspect of the inferior vertebral body. Another mechanism, as we mentioned before, that axial compression can also be important. Some people may develop what's called straightening or loss of the cervical lordosis. So typically we have a natural curvature in the cervical spine that appears like this, but with certain injuries, people can develop this type of straightening of the cervical lordosis. And sometimes it can appear that way from muscular tension, but it's something to note, especially in athletes that are involved in collision sports. When you do have that straightening, the neck is a little bit less tolerable to compressive forces. And so it may put the neck at more of a risk for a fracture or dislocation. In general, with the axial compression, hyperflexion or extension, if there is narrowing of the spinal canal itself, then that may also predispose these athletes to injury. In terms of management on the field, so we're concerned about the spinal cord injury initially when they have these symptoms and they're not able to move their arms and legs. We want to really note the time course that the symptoms are occurring, if they've had any prior episodes or neck injuries. And sometimes video can be helpful to go back and review and say, hey, what exactly happened here? So I want to provide cervical spine precautions and ensure that the athlete is placed on a spine board. During that examination, we'll palpate for cervical spine tenderness, and then also try to work through a brief neurological examination. But there are certain parts of the exam that may be limited, especially if they have cervical spine tenderness. We're not going to want them to really move their neck around too much. So that's where we send them off for further workup and management. Initially, we'll want to grab some x-rays. And so x-rays of the cervical spine with an AP, a lateral, and odontoid views can be helpful. This can evaluate for any stenosis, instability, as well as congenital anomalies. So the clipal feel, congenital effusion can be visualized here. And this is something that we want to evaluate for, as this may predispose the athlete for risk of injury if they are participating in contact sports. If the athlete doesn't have any cervical spine tenderness and their range of motion is restored and their neurologic status is restored, we may be able to add on then the flexion and extension view x-rays down below. So that'll allow us to see, is there any dynamic instability of the vertebral bodies in the cervical spine. Historically, before MRI and other imaging modalities were available, X-ray was used to help evaluate for central canal stenosis. And so typically the measurement was taken from the midpoint of the vertebral body, from the posterior aspect to the spinal laminar line, which is depicted on A here. And so the normal diameter is about 15 to 17 millimeters. And if it's anywhere between 10 to 13, it was thought to be relatively stenotic, and less than 10 is thought to be more universally stenotic. After the x-rays, with those all looking okay, we may want to consider getting a CT scan to rule out an occult fracture. And that can also help us evaluate for cervical canal stenosis. And then MRI imaging can be quite helpful for a number of reasons, but allow us, one, to look at the cervical canal. We can see the space where the cerebral spinal fluid falls around the spinal canal or the spinal cord itself. We can look for any sort of disc herniations as depicted here. You can see some of the bulges back into that spinal canal. And we can also look for osteophytes or bone spurs sort of around the disc as well. And sometimes that can narrow the spinal canal. Also want to ensure that there's not any abnormal spinal cord signal. So that can be concerning for something more than just a transient quadriparesis. And so MRI is very useful in that sense. Sometimes after repetitive injuries to the head and neck, someone may have ossification of the ligamentum flavum, and that can also narrow the spinal canal. So MRI can be helpful for a number of reasons. And the last reason is functional reserve, which is described as basically the ability for that CSF to flow around the spinal cord itself. And that can be important because it really gives us a sense of how much space, aside from our measurements of the canal itself, but it can give us how much space that cord actually has. So with cervical canal stenosis, it is thought to be a risk factor. So think about the mechanism of injury with that pincer mechanism. Having an even more stenotic central canal may put these athletes at risk for injury. And so historically, the torque ratio was used, and essentially that was a measurement of the diameter here from the posterior aspect of the spinal or of the vertebral body to the spinal laminar line over the sagittal diameter of the vertebral body. And abnormal was thought to be less than 0.8 and normal was around 1. But there have been some additional studies that looked at the torque ratio in particular. Torque looked at this in 1996 with multiple different cohorts, but the 45 football players that had TQ in the past, 93% of them had a torque ratio of less than 0.8. And so there is a thought that with individuals that may have a larger body habitus, they may have larger vertebral bodies, which may in turn make that diameter larger for the vertebral body, and then inherently making the ratio lower. So torque ratio is more of a historical measure, and it shouldn't necessarily be used to prognosticate, but it's helpful to know when looking at the cervical spine or looking for cervical canal stenosis. So then return to play. Right? Let's say we have an athlete that we describe in this case. There aren't any standardized consensus guidelines for return to play, but there is a number of different thoughts about how to manage athletes with this condition through various cohort studies, case series, case reports, and expert opinions for those who have cared for these athletes and have seen them in the various settings. There's limited long-term data, which can make it a little bit difficult. And the things that we want to think about when talking to a player about returning to play is main things would be, what is their risk for a permanent spinal cord injury, or are they at a higher risk like we talked about with the cervical canal stenosis? So a couple of different studies here in different settings. Torg, with that study of the 110 athletes, as we described before, 57% of them returned to play, but 56% had recurrence of injuries. Overall, there wasn't any permanent neurologic injury. So what we can take from that is they counseling someone about, if you do have one of these episodes, there is a high likelihood that this may occur again. And then maroon had a small case series, about 5 NFL players with transient quadriparesis, and on their imaging, they also had vocal cord compression. 1 out of the 5 athletes had congenitally narrow spinal canal, while the others did not. And all of them underwent a 1-level discectomy and fusion, and then they had rehabilitation. Additional imaging was done afterwards to confirm that fusion, and 1 player was able to return back at 9 weeks, but the range was between 9 weeks and 8 months in those 5 players. All of them were able to return back, but 2 of them had a recurrent disc herniation, and 1 of those players required surgery. And then another study that was done to look at athletes that had transient quadriparesis and an abnormal cord signal on MRI was Temple in 2015. All of the athletes had a congenitally narrow cervical canal, and all of them underwent having the fusion surgery. They did post-op MRIs, and 4 out of the 5 athletes had partial resolutions at the 3-month mark, and 3 out of the 5 had complete resolution at the 9-month mark. Um, as we 4 of the athletes were allowed to return to play based on their criteria, and 2 of them actually returned. And so the thought, or the discussion here and the controversy is, if an athlete has an abnormal cord signal, and they're symptom free, they don't have any abnormalities on their exam, and no instability on their imaging, um, is this a contraindication for returning to play? And that's a tough question. And I think, especially when we're dealing with either high school athletes, collegiate athletes, and athletes such as professionals who are playing for their livelihood, it's really important to have them understand the decisions that they're making, and give them all the information to be informed. And so put this up here to give just a small dichotomy in terms of a similar type of condition in the spine being cervical canal stenosis, and 2 different thoughts about who can return to play. So Torek said, we believe that those with developmental narrowing of the spinal canal without instability does not preclude them from participation, whereas Cantu felt that if there was any bony or ligamentous instability, of course, but also functional stenosis, were advised not to return back to contact sports. So it really is more of a decision amongst the entire team, rather than just being a clear-cut guideline and a blanket statement for all. So it's very individualized. Some of the contraindications that have been described for transient quadriparesis are listed here. And so when we think about these, definitely having any persistent neurologic findings, pain, or range of motion deficits would be concerning, and we would not want them to return back. Evidence of defects or swelling within the spinal cord, functional stenosis, and then any fractures or ongoing disc herniations. Instability in the spine is definitely a contraindication for returning back to play. And then some other conditions such as Arnold-Chiari malformation, basilar invagination, which is depicted here on the screen. So it's essentially that C2 is invaginating into the foramen magnum, and so that can put additional pressure on the cord as well as the medulla in this region. So that would be very concerning for significant neurologic deficits. And then the ossicle or the os odontoid here inherently puts the cervical spine in a more unstable position, as the dens has 2 different parts here. And then clipal feel, as we discussed before, if people have more than 2 levels of fusion, that would be an absolute contraindication, and if someone has multiple levels of surgery. In the scenarios where someone may have a single level surgery or a single level of clipal feel, I would say this should be a discussion amongst everyone involved. And similarly with fractures, the spiritacular spine with that straightening of the cervical lordosis, And then having a recurrent episode of TQ is also a contraindication. And so these are really helpful to think about when we have these athletes, because it can help us have those discussions and really let them know what they're at risk for and what the consequences may be if they were to return. I just wanted to include this video. It's about 15 minutes. I'm not going to play it, but I just included the link here at the Sports Institute here at UW. There's a video that goes through a lot of the different types of spine boarding procedures in different scenarios or positions of the athlete and with different numbers of staff. And so I think this can be helpful for people to review. And then I have one CAQ question for us to think about here. And so we've got a football player who developed numbness in all four extremities lasting 3 hours and then resolves completely. Which of the following would be a contraindication for returning to play? A would be spinal canal AP diameter less than 15 millimeters. B, multiple occurrences. C, complete neurologic recovery. And D, toric ratio less than 0.9. So I'll let people answer as they choose, and then we can talk about the responses to this one. Right. So it looks like the majority said multiple occurrences would be the contraindication. And then we've got one for spinal canal diameter and then the toric ratio. So I'll go on to the next slide here, which the answer is B, so multiple occurrences. The reason, so as we discussed before in that last slide, having more than one transient quadriparesis event is really concerning for persistent events or further injury to the spinal cord. And so this would be the contraindication. Complete neurologic recovery is not, because that's what we're aiming for. And then A, spinal canal diameter less than 15 millimeters is not necessarily a contraindication itself. As we talked about before with the X-ray, the normal diameter is 15 to 17, and less than 15 may technically be considered a relative stenosis, but that doesn't, the measurement itself doesn't involve the return to play. Similarly with the toric ratio, so toric ratio less than 0.9 was considered to be stenotic. 1 is normal. And so 0.9, having that toric ratio is more of that historical measure. So something that is used to evaluate that region, but we don't necessarily use that in terms of return to play guidelines. All right. Thanks, everybody. I know it's late, but appreciate you all being a part of the lecture this evening, and happy to answer any questions.
Awesome. Thanks for that wonderful and high yield talk as we move into the fall sports, Dr. Booker.
Yeah.
We have a couple questions from the audience.
Yeah.
The first one asks about symptom management, essentially I'm assuming while we're working up kind of persistent symptoms, right? So
Yeah.
they ask if the stinger symptoms are lasting over a day, right? So presumably they get the symptoms, they can't go back in the game. What would you recommend in terms of symptom management? Some of the options they list are Voltaren, presumably oral NSAIDs, steroid like Medrol dose pack.
Yeah.
And then part 2 to that question would be thoughts on things like chiropractic care, particularly with cervical traction. And then other rehab-based exercises like scapular retraction strengthening, as well as nerve flossing.
Yeah. So in terms, I will answer that sort of in the 3 parts that you had there. So for stingers that do last over a day, I think the number one thing that we want to do is figure out why it's lasting longer than that time frame. But in terms of managing the symptoms, I think it would be fine to use NSAIDs unless there was some contraindication for that specific athlete. Medrol dose pack, I wouldn't say it is necessary. Sometimes those are used in scenarios where someone has an acute radiculopathy. And so it's not exactly something that we have to use, but I would maybe try the oral NSAIDs first. In terms of chiropractic care or traction, I would caution the use of that, particularly around the neck, and if there is a neuropraxic injury that we're concerned about, mostly because if there is any sort of high velocity movement at the neck and there may be some narrowing of the foramen, then that may potentially exacerbate the symptoms. And so I would want to avoid making the symptoms worse than giving it some rest and time and then working on rehabilitation, which goes on to the third question, which is scapular retraction and nerve flossing. Those are very well components that are included in the rehabilitation process. And so I think that that would be appropriate to include.
Great. Um, and then Dr. Keller also has kind of a two-part question.
Yeah.
The first one refers to kind of your thoughts on follow-up. I'm presuming from those studies that we're looking at surgical care of the patients with TQ.
Yeah.
Um, and just kind of something that caught my eye too, which was having patients get an ACDF or a cervical fusion, and
Yeah.
then go back and return to play.
Yeah. In terms of the cervical fusion, in general, a one level fusion, athletes may be able to return back to competition if they have full recovery of their neurologic status and also don't have any cord signal, any instability. And I think in general, the discussion needs to be with everyone involved. Um, and also depending on their level, like if this is a high school athlete that's getting a cervical fusion in order to go back and play, that's pretty concerning and may be even more conservative with that athlete to say, hey, we shouldn't go back to play a collision sport. On the NFL side, as we saw with those studies, is that some of the athletes have returned to play, but there have been recurrences where they have another injury that may occur above that level of fusion or below. And so that would be one of the concerns with getting adjacent segment disease. And so I think there's not one specific answer for fusion, but if someone has one level done and no neurologic symptoms or other concerns, then that athlete may be able to return back to sport.
Nice. I think that makes sense. And then lastly, I appreciated how you discussed on-field assessment of these injuries and
Yeah.
made sure to keep a broad differential with probably the most dangerous things at the top earlier on in your assessment, namely spinal cord injuries. And so when you're assessing that, how do you like to do things? Do you like to remove the helmet entirely, leave it on, and maybe just remove the face mask and chin strap for football? Do you have any thoughts on that?
Yeah. I think part of it is depending on your setting and overall the emergency action plan at the facility that you're working with and the team that you're going to be working with. Um, I would, in a high school setting or a setting where you're maybe not as familiar with all of the medical staff that you'll be working with, you may want to leave the helmet on and just remove the face mask. And when they're transported to a high level of care, they'll be able to work on getting the pads and the helmet off. If you and your team are all cohesive and have practiced and are all on the same page about removal of the helmet, then I think that that would be fine to do. But in general, we just want to make sure that the face mask is also that we have access to the airway.
Yeah, no, I totally agree. I think that if as long as you've practiced removal of pads with your team,
Yeah.
It's worth doing, especially because I don't know, out here in Texas, some of our rural EMS crews aren't as experienced with this type of thing, and so sometimes we leave pads on, but yeah, there's a risk of worsening any kind of spinal cord injury
Yeah.
while you're removing pads. So
Yeah, and I think too, like the resources also matter. Different settings may have EMS on site, like similar to when we were in fellowship at Utah, the EMS was at every game, but that's not the case necessarily here in Washington. And so that also changes how quickly and how you go about working with the EMS staff and the facility that they'll be going to. Yeah.
ready, guys. I think those are all the questions that we have. Thanks again, Dr. Booker. This was excellent. And happy coverage, everyone. Hope now that we've talked about this, we don't have to see it for a long time.
Yeah, absolutely.